Hi guys, I'm going to talk about a case that I saw in my vascular surgery rotation. This is a patient that ended up having an acute limb ischemia. It wasn't super obvious at first because he had kind of an atypical presentation due to peripheral neuropathy that he also had. The patient is a 74-year-old male with a past medical history of type 2 diabetes, hypertension, hyperlipidemia, coronary artery disease, liver disease, COPD, and peripheral neuropathy. So basically, he just has pretty much every cardiovascular risk factor. He's also an inmate at the local prison, and 4 days prior to him coming to the ER, he had just developed this generalized right lower leg and right foot pain. He does have neuropathy, but feels that this pain is just different. He describes it as dull, constant, non-radiating, and rates it a 5 out of 10. He says that the pain is worse with movement, and he does have lack of sensation in the feet, but then has felt loss of sensation in the lower leg as well. There was no known injury. He's not having any chest pain or shortness of breath. So the ER provider ran a super good workup and physical exam and ruled out stroke. I think that's what everybody was thinking at first, just because this was so nonspecific and this pain and numbness was just kind of not what you would expect with like an ischemic lower limb. But the provider then examined his legs and then called vascular surgery because he had a high suspicion for acute limb ischemia. So, relevant social history: he had a 35-year pack smoking history and an extensive history of alcohol use. Family history includes diabetes and heart disease. His current medications included meds for diabetes, hypertension, and hyperlipidemia that he was receiving in the jail. Vitals were kind of non-revealing. He's a little tachycardic, somewhat hypertensive. Respirations were a little high, but otherwise kind of non-revealing, nothing super surprising. And then the differentials listed there. His only positive review of symptoms included positive for right leg swelling, and then the pain that he was experiencing that was suspected to be claudication. He was having muscular pain in the right lower limb as well, and then that loss of sensation that we were talking about earlier. Otherwise, review of systems was negative. Physical exam was pretty much the same way. He was just overall ill appearing, but that was kind of expected to just be baseline for him. He was somewhat disoriented, but his A and O was ×3. Skin changes were noted over the right lower limb, kind of a cyanotic appearance with white blotches over the dorsal foot, and then also dry and cold, pulseless, were kind of the keys to a limb ischemia. His eyes were somewhat jaundiced, but with the liver disease, that was expected. And then for musculoskeletal, there was no palpable pulse. There was a cyanotic appearance, cold, and then there was loss of sensation over the right foot. He was also unable to successfully passively move that foot. We were able to see the ER labs that came through. So thankfully, the prison's EMR and our EMR were linked, so we could see his previous results from just the past month. So things that obviously really stood out to us were the lactic acid of 4.1. That's a very critical value. He had evidence of uncontrolled diabetes with a blood glucose of 280, and then just his liver disease, AST 75, ALT 99, and then bicarb was 20. But other than that, all their lab values were reassuring. His blood cultures were pending at the time we went to see him. So the things that we did for a further vascular workup were arterial Doppler and a CTA. So arterial Doppler we could do right then, so we could kind of confirm that there was an arterial occlusion, but then we needed the CTA for the surgeon so that he knew exactly where he would have to do the thrombectomy. This patient would obviously have a really extensive care plan in place while he was inpatient, but vascular specifically, he was placed on unfractionated heparin just until we could get in and do the thrombectomy. He was also put on an insulin sliding scale to address his uncontrolled diabetes. So with the arterial Doppler and CTA results, we were able to see exactly where the clot was. So this isn't my picture, but you can see how on the left there, the blood flow just kind of stops, and then the picture right next to it is after they revascularize it. So this looked super similar. Our patient's clot ended up being like in the distal superficial femoral artery, I believe. So this is pretty much the exact same situation. Skills and procedures I was able to perform were the arterial Doppler readings. So this on the right, this picture, is an example of what the sheet looks like. We didn't do this extensive of a workup for him just because we knew that it was located at the right, and we just needed generalized waveforms at the different anatomic sites just to see just to guesstimate where the clot was occurring. So this is on a completely different patient, but you can see the waveforms. They would, if you imagine them just being flat, like there's no pulse, no waveform, and that's what it looked like. So that indicated to us that he was having a critical limb ischemia. The long-term care plan for this patient was just to optimize his cardiovascular status. So he would be expected to have like an extensive follow-up with our vascular team just because his disease was probably so widespread and he would need other surgeries most likely. We spoke with the hospitalist and they did begin him on an insulin regimen. They also completed diabetes and nutrition education while he was inpatient. He likely became an insulin-dependent diabetic at some point, but it was just never addressed because he was in the prison system. So he was established with an endocrinologist and then also with a pulmonologist that travel around the prisons. He was continued on a statin and then was added another agent for the cholesterol control. And then due to his CHA2DS2-VASc risk, he was anticoagulated with Eliquis. So this was just a super interesting case because it was definitely an atypical presentation. Typically with limb ischemia, we think of like paralyzing pain, but because of this person's peripheral neuropathy, they didn't necessarily have that. So it really just emphasizes the importance of a really good physical exam and really getting a good history from your patient. Thank you.